Why don't we get started since our time is short together? I'm Megan Swain, Associate Director here at CCPR, but I'm formally playing the role of Martha Bailey today, who is out of town. So I get the pleasure of introducing our speaker, Dr. Sarah Miller. Sarah Miller is an Associate Professor at the Ross School of Business in Michigan. She's currently on sabbatical at UC Santa Barbara. She is a health economist who got her Ph.D. from the University of Illinois, Urbana-Champaign. Her work focuses particularly on the effects of policies expanding health insurance coverage and the effects of income and other social programs on health and well-being. She is the 2022 recipient of the ASHEcon Medal, which is an award given by the American Society of Health Economists for the most significant contributions to health economics by an early career economist. And with no further ado, her talk today is titled, "Does Income Affect Health? Evidence from the OpenResearch Unconditional Income Study." So take it away, Sarah. Thank you. Welcome.
Thank you. Thanks. Wow. What a nice introduction. Thank you so much. So I'm really excited to be here today to talk to you about this study. This is joint work with Beth Rhodes, Alex Bartik, David Brockman, Patrick Krause, and Eva Vivant. And in this project, we're looking at the causal relationship between income and health by studying kind of a randomized income supplement. So before I get started, I use a very small amount of US Census Bureau data here. I know there's an FSRDC on campus, so I'm sure you're familiar with these kind of disclaimers, but none of the results are the view of the US Census Bureau, and all of the results have been reviewed by the DRB to prevent any inappropriate disclosure. Okay, so to get started on this, part of our motivation for looking at this relationship between income and health comes from the fact that this relationship or the correlation between income and health, sometimes called the income-health gradient in economics, is one of the oldest and strongest and most widely documented patterns in the social sciences, that people who have higher income or have higher socioeconomic status tend to also be in better health. So you can see this for basically within every country in the world, including very high income, low inequality countries in Northern Europe to lower income countries. You can see this across countries and cross-sectional correlations. You can see this for every period of life, starting at infancy, where infants born into low-income households have twice the infant mortality rate as those born into high-income households, going all the way up through old age. Right? So this is like a really striking pattern that we have these really strong differences in health across the income distribution. And I just want to emphasize that these differences in health between rich and poor are not small. They're not statistically significant, but small. They're actually really, really massive. So there's many papers that look at this. One that I like is by Chetty and co-authors, published in JAMA in 2016, that shows conditional on surviving to age 40, a man at the top of the income distribution can expect to live about 15 years longer than a man at the bottom of the income distribution. And the difference is about 10 years for women. So, conditional on being 40, like getting to age 40, a decade and a half is really a lot of the expected life that you might think that you would have, right? Really, really big differences across the income distribution. Now, of course, we know that just because things are correlated, it doesn't mean that there's a causal relationship there. But I think at least in the context of the US, it's plausible that there could be some causality driving some of this correlation that we observe, right? The US is the only wealthy country that doesn't have some sort of national health insurance scheme or national health program. And so low-income people in the US are more likely to be uninsured. They're more likely to experience spells of uninsurance throughout the year than their higher income counterparts. They're more likely to report in surveys that they're skipping necessary medical care than their higher income counterparts, that they're skipping prescription drugs that they need. So there's clearly a potential use of medical care channel. They tend to report getting worse nutrition, lower quality sleep, more likely to report that they're sleeping less than 6 hours per night. And you can imagine that all of these things could be, as economists would say, normal goods, and that if we gave people more income, they would spend more on these goods, on these health inputs, and have better health as a result. Okay? So this is kind of this, health input, health output idea. Economists tend to think of this as we have some kind of health production function. Cobb Douglas probably, right? And the more of these that we get, the better health we're going to have. And if these are normal goods, we're going to consume more of them when we have more money. There's also kind of a literature more from the biological or the medical side that looks at the sort of causal biological pathways through which income can affect health. It does things like scans the brains of people who have low income, finds that there's more evidence of amygdala activity that generates stress in the body, inflammation, and this inflammation can kind of causally, in the biologic sense, like lead to cardiovascular disease or diabetes, et cetera, right? So we might think that there's also kind of a stress pathway potentially here through which income can affect health. And this kind of constellation of correlations has caused a lot of policymakers and advocates in the health services research space to start thinking, well, maybe the underlying cause of these health disparities is not something that can be addressed on the medical side. Maybe this is something that we need to kind of address poverty first, and then the health improvements will come. Or sort of put differently, if we have kind of one more dollar that we might think about spending to improve the health of some of the people in our population, maybe it's better to spend that dollar addressing people's material needs, just giving them cash, than trying to address their health needs and get them to consume more medical care. Of course, this logic relies on the idea that these correlations are, in fact, capturing something causal between income and health.
I'm just going to remove it.
Oh, okay, yeah. Great. So that's where our jumping off point is here. If we did, do that thought experiment, we have some additional cash we want to put towards addressing people's material needs or doing a cash transfer, would there be a health payoff? So we're going to look at this in the context of this OpenResearch Unconditional Income Study. Oh, yeah, please.
Yes, so, so health income sort of gets you all these nice inputs, but the other thing it helps is insurance. So just in terms of emergencies, et cetera, including medical emergencies. So given you've got, say, 1,000 participants, I mean, how likely actually are you to get a medical emergency in sort of the set?
Yeah, that's a really great question. So, so one thing I will show you, maybe this is working backward from the results to the theory, but we do find that people go to the emergency department more and go to the hospital more when they get the money. So to me, that
emergency room could just be, okay, it's after hours, you can't see a doctor, or there's a really long wait line for the doctor, so you go to the emergency room. It's not necessarily just sort of really something big that hits you in terms.
Yeah, I mean, I guess there's a couple ways to think about this. So this money might go into, healthy behaviors or using medical care that kind of, improve your management of a chronic disease, that make you feel healthier, feel better. You might have fewer asthma attacks. Maybe they never result in a true medical emergency, and that might improve your health that way. But something like you have a heart attack and you're laying on the ground, maybe that's not prevented, and maybe that's not actually something we're going to measure. But I think there's a lot of ways it could improve health besides just preventing these kind of really big emergencies. I don't know if that answers your question. Maybe when I do think the hospital and emergency department results speak to this a little bit, because typically when you're staying overnight at a hospital, it's typically for something that is more serious, right? They're not going to admit you to the hospital for something that's just, I have a sore throat and I couldn't get into my primary care. Yeah, that's a great question. Okay, so the study, we had 3,000 participants. Of the 3,000 participants, a third were assigned to receive $1,000 a month for 3 years. The other 2,000 served more as a control group and received $50 a month over the same 3-year period. So there are some reasons to think this might be a good sample to look for these type of mental and physical health improvements. It's a low-income sample. I'll describe it a little bit more in a little bit more detail in a few slides. At baseline, they report relatively high rates of saying they have unmet health needs. So about a quarter of them say, or a little bit more than a quarter, say they need some medical care and they can't afford it. About a third say that they need some dental care that they can't afford. So you might think that that makes it kind of plausible that at least for that subset, there could be some improvements. And so we have the sample we're going to study, and we collect a wide range of information on what we might think of as health inputs, saying you're able to access all the medical care you need, going to the doctor, getting, you're able to access prescription drugs, the food, the nutritious value of the food that you eat, and things like the amount of exercising and unhealthy behaviors, things that might relate to your health either in the short or long term. And then we also collect different measures of health outputs. So you can think of self-reported physical health. Of course, mental health is also important, and we might think that getting this cash transfer could drive improvements in mental health. So we look at physical and mental health. We have some measures of kind of clinical measures of health derived from blood draws, and we have some administrative data on mortality, although that's very low in our sample. So what do we find? We find that the treatment group experienced relatively large, but short-lived improvements in mental health. So things like stress or mental distress improve a lot in the first year, but by the second year, they kind of return to baseline, and the treatment and control groups are reporting no difference in mental health by year 2 of the study. We do see that they did use more medical care. Particularly, it looked like they used more emergency department and hospital care. They report going to the hospital more often, going to the emergency department more often, if you're in the treatment versus the control group. Yeah.
I know you're going to get to the details on this, but I think a lot of us work in a world where increased ED use would be a bad outcome. It's not a question.
Yeah. Well, I guess so this is what we find, and you can attach the valence to it that you wish. Certainly, I think there might be a hope that if you got more primary care, you could avoid emergency department visits in the first place or hospitalizations. On the flip side, if you really need this kind of more, and this tends to be it's very expensive to go to the ER or the hospital. So you might imagine that that's something where there are big financial barriers if you're uninsured or if you are in a high deductible plan or you have coinsurance. And so you could imagine if they have some unmet need for this type of care that they're not getting because they are afraid of their deductible, for example, then you might see this as being like a good thing that they're getting the care they need.
But if you wanted to support that, like financial barriers are the reason why, could you just do some heterogeneity and show us if the largest results are coming from the lowest of the lowest SES? Are you going to show us heterogeneity?
So I have, I don't, so there's a lot of outcomes, obviously, and I didn't put all of the heterogeneity stuff in the slide deck, but you can definitely look in the paper and see the heterogeneity for every outcome that I'm going to show you. I'll say the biggest effects are not necessarily the lowest SES. The biggest effects are among people who report at baseline, I need medical care and I can't afford it.
Okay.
So basically for every single thing we find, so like the increase in the hospital care, the increase in the dental care, basically every single thing, it's biggest among that particular group. Good question. Yeah.
And there was no increase in primary care use or specialty care?
So, I'll show you the slide. So it looks like a little bit of an increase in office-based care and specialty care, but it's not statistically significant consistently, and it doesn't survive our adjustment for like multiple hypothesis testing. But I would say if you kind of looked at it and took a step back and maybe squinted a bit or viewed it a little bit generously, it does look like maybe a little bit of an increase in specialty care and office-based care in general. And so overall, office-based care goes up and it's significant with traditional inference, but not after we account for the fact that we're testing so many outcomes. Yeah.
You have data on whether they're insured or if that changes?
We do have data on whether they're insured. We don't see a change. They don't, there's no significant difference in the rates of insurance across the treatment arms.
Where I guess there's both the change in access to insurance over the course of the intervention, as well as heterogeneity in terms of the type of insurance that they have.
So we see that they spend, getting a little ahead of myself here, but we see that they spend about, of the $1,000, they spend about $13 on higher insurance premiums, right? So that could reflect getting slightly better plans or, slightly different plans, but it's not a big chunk of the money that is going towards insurance plan quality. But that's kind of the measure that we have of, within the private plans, like the type of plan that they're getting, right? We see some possible, again, these results are kind of significant after adjusting for multiple comparisons. if you just want to look at kind of traditional methods of inference and not do the adjustment, we see maybe there's some changes in use of alcohol, maybe some decreases in reporting, drinking so much that it's interfering with working or my responsibilities. Maybe some improvement in some measures of the nutrition that they're getting. So not, again, super precise, but at least pointing in that direction. But when it comes to the actual health outcome measures, either the overall effect on mental health or the measures of self-reported physical health or the clinical measures of health, like their blood pressure or their blood sugar, we don't find any change, at least over this 3-year period that we studied. And we can reject even kind of very small improvements in physical and mental health with our data. We also can rule out for a very large number of these outcomes that this cross-sectional correlation between income and health that I kind of motivated the talk with is fully causal. So the cross-sectional correlation within our sample would imply that we should find really big effects on health, but those lie outside of our confidence intervals of the actual treatment effect of health that I'm going to show you. Great. Okay, so there's obviously a huge literature on the relationship between income and health. There's lots of great papers that document health differences across the income distribution. I'm just going to talk very briefly about a few papers that I think are the most closely related. So my apologies if there's a paper you really like that I hadn't put up here. I think the ones that are really the closest to us are other US-based RCTs of cash transfers. There are some, and they're kind of more and more every week. There's been a lot of interest in this, and so the evidence base is growing. The three that I think are the most relevant are Baby's First Years, where they randomized mothers, 400 mothers giving birth in 5 cities in the US to receive either $333 a month in the treatment group, or I believe it was $20 a month in the control group, 600 control and 400 treatment. And they look at effects on like the infant and the mother's health, but they don't find much evidence of changes in either of those sets of outcomes. Chelsea Eats was a 9-month kind of pandemic era relief program that was done in Chelsea, Massachusetts, where they gave $500 a month to a randomly selected group of people. This was kind of mid-2020 through very early 2021. The initial results based on surveys didn't find any significant effects on health, but kind of a reanalysis using administrative data found some evidence of decreases in emergency department visits associated with the program. And then just very recently, you guys, I hope you're all familiar with this one since it took place in LA, but the Los Angeles Big Leap RCT had 3,200 participants receiving $1,000 a month for a year. They actually found somewhat negative effects of the transfer on mental and physical health in their survey data, which was surprising, but they have relatively high differential response rates across treatment and control, 30 to 40 percentage points. And so, of course, they try to account for this with imputation, but this kind of surprising result might still reflect a little bit selection if the imputation is not, completely perfect. And then, of course, there's also a big quasi-experimental literature that I think is also somewhat mixed that looks at things like expansions of the EITC or random lottery prize sizes, et cetera. Yeah.
Are you gonna discuss at some point whether maybe the relationship between income and health isn't necessarily constant in terms of income, or maybe like, I mean, if you're making, let's say, $500,000 a year, then I mean, you can afford maybe a bigger house with an indoor gym, inside gym, a pool, and like that.
Yeah.
You have be healthy and organic food.
Yeah, well, I mean, certainly a different size transfer could have a different effect, right? Like if, we gave them a smaller transfer, maybe the effects would be smaller. If we gave them a bigger transfer, maybe the effects would be bigger, right? And so we're just going to study the variation that we have. That said, I think from more of a public policy perspective, giving poor people $1,000 a month is probably already sort of too large in terms of what might realistically turn into a policy that policymakers would consider. I think especially now in the post-inflation, post-CTC, post-Trump re-election, world, I think it's an interesting academic question. If we gave them $5,000 a month, would they have big effects? But it's just, to me, it seems a little bit overly academic.
Is that a month and then to affect your eligibility for other transfer programs, et cetera, also the ITC status?
Yeah, that's a great question. So we were what we didn't want was to give people $1,000 a month and then $1,000 a month of benefits gets taken away. Because then, of course, there's not going to be an effect, right? So we worked really hard to try to protect the benefits that people had and maybe already were qualified for. So I'm gonna, let me go to the next slide, actually. It might be, see what's on there. So as I'm about to say, this took place in 2 states, Texas and Illinois. In Illinois, we actually passed a state bill with the help of our nonprofit partners saying that these payments were specifically excluded from Medicaid, food stamp, TANF eligibility. And they actually changed the handbooks that social workers use to enroll people in Medicaid to say, you should not count this towards income for eligibility. In Texas, we were only able to protect Medicaid, so it did potentially affect food stamps and TANF eligibility. The good news is that Texas actually is very stingy with its low-income people, and so there wasn't really a lot of benefits that they weren't getting so many benefits, right, to get taken away. I think that the first so many $100 per quarter was protected, and then it could affect eligibility. But we didn't find really big differences in eligibility across, in self-reported enrollment in these programs across treatment and control groups. So I think the benefits protections kind of did their job for the most part. Yeah. So the study takes place in Texas and Illinois. We wanted to have one more, quote unquote, blue state, high benefit state, one more low benefits, quote unquote, red state. And we had a sort of mix of rural, urban, and suburban counties that the study took place in. So around Dallas, and then rural and suburban and medium-sized urban areas around that, and around Chicago and Illinois. To be eligible for this study, your total reported household income in the prior year could not exceed 300% of the federal poverty level. We recruited people aged 21 to 40 at the time they were recruited, so about 24 to 43 at the end of the study. We also excluded applicants who were already receiving SSI or SSDI, since you're already kind of getting a guaranteed income through that program, as well as those living in public housing or using a housing choice voucher or living in a house with someone receiving SSI. We weren't able to protect the housing choice voucher program except within the city of Chicago, right? And so we were, this is a very difficult program to get onto. And so we were worried in Texas, particularly if people were on it, they got this money, they got kicked off, be very hard to get back on. Same with SSI, yeah.
So will you be able to tell us something about the children of these people? Because if I got an extra $1,000 a month and I was strapped for money, I would spend it on my kids.
Yeah.
And their health.
Yeah, so in this presentation, I'm just going to tell you about the health of the adults, but we're working right now. We have collected data on the kids, and we're hoping to have some results on that early-ish next year. Well, we'll see how quickly it goes, but we did collect data on them, and we also have been able to link them to their school outcomes and stuff. So to be continued, I guess, on the kids, but that's a great point. Okay, so here's a high level overview of kind of what we did in the study. So first, we recruited people to the study. Most of the people we recruited using direct mailers, using addresses that we purchased from the marketing organization. And each mailer had a unique code. You could sign on to a website, and it said, you can be chosen to be in a program that will give you $50 a month or more. So we think this is potentially an important part of how we recruited people, was that they thought they were getting $50 a month or more. So if they were chosen to get $50 a month, they weren't necessarily disappointed that they weren't chosen to get the higher amount, right? We didn't disclose at the beginning of the program what the higher amount would be, right? We had a little bit of trouble with the mailers getting the very lowest income people. So we also recruited some people through a program called Fresh EBT, which is what's used to manage food stamps and TANF benefits. About 12% of the sample had a Fresh EBT banner that also said, you can get $50 a month or more. And we experimented a little bit with Instagram ads, but they didn't end up being super effective. So that's only about 1% of the sample. Of everyone that filled out the screener online, so they put in their information on eligibility, and they also consented or didn't to share their administrative records. There were about 43,000 of those. Of those, about 14,573 were eligible for the program on the basis of the age and the income criteria, and the benefits criteria I just described. So then, once we had these eligible individuals, we did 2 randomizations. First, we randomized people to kind of being in the program at all. This first randomization was not unconditional. It depended on your characteristics. So we oversampled low-income people. We oversampled racial and ethnic minorities. We oversampled men. We were trying to get a sample that was roughly representative of the population on some dimensions, but also overrepresented some groups like racial and ethnic minorities that we wanted to make sure to include. So this randomization, your probabilities could be different. Once we enrolled all 3,000 people, we collected baseline information about them. We got their bank account information so we could make direct deposits. They didn't have a bank account. We opened a bank account for them. We got 3,000 people enrolled, and then we did a second randomization either to continue getting the $50 a month, which everyone got as soon as they were enrolled, or to be informed they were going to be in the $1,000 a month group. Adriana?
Good question. Did you oversample people in bad health? You're looking at prime age adults who
Yeah.
are typically pretty healthy.
Yeah.
To start with, even though they're poor.
Yeah.
So I'm just wondering about that.
We didn't. I would have loved to. I'm a health economist, so I'm really interested in health. But there were also labor economists and people interested in other kind of questions as well. And I also am interested in those. Those are also important, right? So we chose to sample these kind of prime age individuals because we thought this was a period where if they were going to do something like get married or have another kid or go back to school or switch careers, this was kind of like the most likely age group where we would see that, right? And so it was not for health reasons, but it was to capture those other kind of potentially important outcomes that we use this prime age group. That said, we are working on some follow-up studies with the city of Chicago and Cook County where there's no age criteria, and this includes people up in retirement age, and we're hopefully going to be able to say something about cash transfers to the older group as well.
So who in the household controls the money? Say, is it the mother or the father? Or is it just whoever's account you dump it in, you put it into?
Yeah.
Yeah.
So logistically, this was a really important thing, and we debated, should we try to treat a whole household or should we just try to treat a person? At the end of the day, it's really hard to treat a household because let's say you have people that are married and then they get divorced and then they get remarried. Like how are we going to make sure the money is flowing the way we want to? And so in the end, we decided that it's an individual gets selected, that the money follows that individual, right? And so it can't be transferred to someone else. It's, if you break up or whatever, the money goes with you.
Let's follow up. So you wanted to study a lot of different aspects, and I know you have some other papers on this. So could you remind us, in terms of the other outcomes, like what else people did with their life? Because I think that, I guess the question is, was this money enough to change the way people live? Or did they just perceive it as like, okay, for 3 years I have this reprieve and then it's over. So they treat that money differently, and it's not kind of the same as if you got a good job that paid $1,000 more, but led to something else, or, had a different impact on your life altogether. So I'm just curious what else you found about their behaviors.
Yeah, no, that's a great question. And I think, so first I'll say, I think part of what I'm hearing in your question is this is a temporary income shock or a transitory income shock. If it was a permanent income shock, it might be really different, right? So
Could be.
it could be, right? But it could be, who knows? In terms of what else changed? I mean, obviously consumption went up. Basically proportional to the percent of their baseline budget, right? So the big ticket items like food, housing, transportation, spending on kids all went up the most in dollar terms. People moved a lot. That was like a big thing we found. They moved to different apartments within their neighborhood. They moved to different neighborhoods, they moved to different labor markets. So we find really big effects on moving. We find reductions in labor supply. About 35% of the transfer went towards leisure, in the sense that they were earning less from the labor market. They were working a bit less. Extensive margin changes of labor supply, 1.5 to 2 percentage points, and then about 1.4 hours per week intensive margin reductions in labor supply. So it seemed like it was kind of a combination of increased consumption across a lot of categories, and more leisure. And then of course, when we add all the numbers up, because it's hard to measure consumption, we do have a chunk that's just kind of unaccounted for that we're trying to figure out. We don't see really much in terms of savings over the period. So it doesn't seem like they use the money to like pay down debts, for example.
Or go to school, train.
We find some maybe suggestive evidence that the younger people in the sample did some more training or did some more, got some more education. But when we look at things like job quality, I mean, like one story people tell is, you know, you might reduce your labor supply, spend more time searching when you're unemployed, and then have a better job, right? Like we asked about tons of characteristics about their jobs, which is really unusual. Usually you don't have a lot of information about people's jobs, but we don't see like job quality changing a lot. And overall, we don't see an increase in education. Again, maybe in the heterogeneity, maybe some of the younger people got more education.
And so did the labor supply decrease fully offset the transfer in terms of family income?
No, so they still ended up ahead. Like if we just looked
By
at
how much?
how much more they were ahead. I mean, they were still ahead by like $650 a month, and $350 was consumed in leisure, let's say. Yeah, so it was still ahead on that. Yeah. Oh,
You have a question?
Yeah, you said the intensive margin was like 5 or 6 hours. What's the baseline on that? Is it like they're cutting their second job, or are they like cutting their hours at their primary part-time job?
let me pull up the descriptive statistics. Oh no, it's okay. So I'll there's a couple small things about randomization. We clustered a couple of participants together. And I can talk more. I mean, I can talk more about the randomization, but I think maybe this will be helpful. So, you know, some people weren't employed at all to begin with. About 58% were employed. And I want to say, on average number of hours worked among people who are employed, and you can check the paper on labor to make sure I'm remembering, it was not like 40 hours a week, right? Like, so you can see like a lot of people had kids in the house. It was, more female than male, which is true of households that are the lowest income because they tend to be female-headed households. I mean, I think it was like a 5% reduction in hours. Yeah. So it was significant, and it definitely represented this. And we also saw that other people in the household reduced their earnings a little bit as well. So it was a significant decrease, but it wasn't like half of the sample immediately exited the labor market. Yeah.
You know anything about housing security or homelessness?
Yeah, I don't, we have data on that, but I don't think that outcome has gotten like cleaned up from the surveys and analyzed yet. We do know about moving, and we know about other measures of material hardship, like I'll show you food security.
If we were to compare the bottom panel on health with population with similar demographic characteristics, would we find an insurance rate of 70 to 72%? Like are 72% of Americans, among these demographic groups insured? Like what would that look like?
Yeah, I mean, so if we conditioned on income also, I think this is about right. It's about 30% uninsured. Half the sample is in Texas that doesn't have Medicaid eligibility for low income people. So if you're low income, if you're under 100% of the federal poverty level in Texas and you want insurance, you have to just pay for it out of pocket. So, and it's a relatively young age group who tend to have relatively high uninsurance rates. So I think this is conditional on income. I think this is about right. If you compared this unconditional on income, if you include higher income people, of course, all of these look better. Yeah.
Very, very quickly. About the transitory nature of the intervention, did people go in knowing it was going to be going on for exactly 3 years, or did they know it was just temporary?
We told them it was exactly 3 years.
Okay.
Yeah.
Thank you.
And we reminded them we didn't want people to be surprised, obviously. Yeah.
So your question about the rental hospitalization and your visits, I mean, I don't know what those numbers are for the population, but it seems pretty, relatively high to me. I don't know if you have any idea of what type of reasons people are going into the hospital for.
Yeah, we didn't ask them like what was the diagnosis or like what are the diseases that you have, and part of that is just we're already asking them tons of questions, so we didn't want to make the baseline survey like so unbearably long. But these are for this age group, these are relatively high. I think if you looked at the whole population, unrestricted by age, it's about like 0.25 emergency department visits per year. So I think it's, it's maybe higher than you might expect, but for a young group, these are definitely higher than what's typical. And I think, again, that reflects in part the fact that it's a more disadvantaged group to some extent. Yeah.
Those are for self, not kids.
This is for self. So this is all going to be about the participant, the selection participant, him or herself. Yeah, so I guess the only other thing I would flag here is about 30 years old, about 30% non-Hispanic Black, a little bit under 50% non-Hispanic white, about 22% Hispanic. And then just their baseline income, personal income is only about $21,000 a year. Household income is a shred under $30,000 a year. So this is a very large transfer, about 40% of their household income. So this is not, this is like a pretty substantial amount of money. Yeah.
Which sort of households have zero income? Like, do you have those households that you can look at and examine for treatment effect heterogeneity?
That's an interesting point. I don't think we looked at zero income specifically, but we did look at sort of low, medium. I don't want to call 200 to 300% of the federal poverty level high, but like under 100, 100 to 199, and then 200 to 300. But we didn't, as I mentioned, we didn't find a ton of heterogeneity across that dimension. A lot of people's income fluctuates. So you might have been 100 this year, next year 100 to 200, the only heterogeneity, as I mentioned, was kind of the people who at baseline were like, I have been skipping doctor's visits I need because I don't have enough money. And even that, I should just be clear, is like, it's like kind of suggestive given all the tests we're doing, but interesting. Oh, yeah.
I remember from Medicaid health experiments, giving people insurance improved some measures of well-being, improved often they went to the doctor, but also didn't improve any health outcomes. And that's a much more direct channel in some ways of giving people income. We weren't expecting outcome here. Would it be through?
Yeah.
Something not through the healthcare system, right?
Yeah, I mean, I think I think there has been subsequent work that has shown that, in larger samples, giving people Medicaid, like there was a really nice IRS experiment where they randomly nudged people to sign up for Medicaid, and they found really big, health improvements from that. So I would, I guess I love the Oregon Health Insurance Experiment, but I wouldn't take, away that like there's no effect of getting medical care on health. I don't think that that's true. But it's definitely true that that is a really direct effect. And I think it's kind of interesting to compare to this indirect intervention when you think about bang for buck in terms of like, oh, if I want people to go to the doctor more, how does giving health insurance compare to giving cash? And I can say that, these people spent a little bit more money on medical care, but they spent like 700% more on medical care as a result of the Oregon Health Insurance Experiment than as the result of the cash transfer. So I don't know if I said that clearly, but that's kind of one takeaway for me. In terms of like what channels could be relevant, I mean, I think personally, from what I read before I saw the results, I thought the sort of stress channel was kind of the most plausible. You experience a lot of stress because you're low income and you can't meet your material needs. And then that has like biological consequences in terms of like inflammation in your health and things like that. Of course, the other two channels I mentioned, like behavioral changes, like better food, more sleep, etc., or getting more medical care, I thought were also plausible, but I don't know if that answers your question, but okay, great. So the intervention, so we started payments in November of 2020, and they continued until October 2023. So we just finished 1 year post payments now. The program itself was administered by a local nonprofit in each state, and these were unconditional gifts from a nonprofit. Excuse me. That was important because they're not taxable in that case. So if we said we're going to give you these payments, but you have to do surveys for us, well, now we're paying them for some kind of work, and that's taxable income. So they did not have to pay taxes on the payments. And as I mentioned, most government benefits were protected. Some in Texas were not protected. We did protect Medicaid in Texas, but there was some effect on food stamps and TANF in Texas. But again, those rates were pretty low to begin with. So.
Can I ask you
Yeah.
kind of an unrelated question?
Yeah,
Which
of course.
is, What was the did the motivation for this come as a result of COVID, or was it just completely unrelated to COVID and it just happened to start payments in November 2020?
It was, that's an interesting question. So it was unrelated to COVID. So the motivation for the study, this was actually something that Sam Altman said he wanted to do, and an expensive study, and he paid for a good chunk of it. And his motivation was that he thought AI was going to like really massively disrupt the labor market, and we would have to think really differently as a society about how we would distribute resources. And maybe basic income was that solution when AI took over, takes over everything, et cetera, right? Like, so this, well, this was 2016, and I was like, okay, like, OpenAI. So OpenResearch is the organization, right? OpenAI is part of the OpenResearch family of organizations, and I guess he knew what he was talking about. So, but that was the original motivation, not necessarily even from like a poverty alleviation standpoint. Lisa.
Relatedly, like, it seems like this is kind of a weird period where there's like a lot of money floating around.
Yeah.
For people. Have you tried to like, I don't know, exclude 2020 and 2021, or like I'm sure you've thought about it.
Yeah. So I mean, the 20, especially the beginning of the period, there was like the enhanced UI, there was like the child tax credit. So there was just kind of a lot of money going on. Before we did the study, we pre-specified that we would, so we collect data in each year, and then we want to have just a single number, right, to show you. And so we kind of pull those together, but we weight the end more heavily. So the last year gets most of the weight, the middle year gets a little bit less, and then the first year gets much less. Of course, as I'm going to show you, we find all the biggest effects in the first year, which I think you might expect to have the smallest effects because the control group was getting a lot of money also. I'm not sure. So,
I mean, I think it's not like a problem for internal validity. I think it's more like an external validity thing of like thinking about sort of the baseline income of people.
Yeah, no, I mean, I think that's true. I mean, I think we show everything by year, and I think if you're really concerned about this, you can just look at our last year effects, which are mostly 2023, and I see that as kind of a last year felt a very post-COVID to me, and a lot of these programs had already expired. So, of course, there's always things that are particular about any point in time when you do an experiment, and there was inflation, there was a lot of things going on, but yeah, that's why I report it kind of separately by year as well. Okay, so we're getting data from a couple of different sources that I'll tell you about. So we did monthly online surveys, or kind of like phone surveys that were short. We tried to keep them in about the 5 to 7 minute range. Why did we do monthly surveys? Well, the sample is very mobile. I just said they move a lot. This was a chance for us to get updated contact information. If we sent a survey and it went to a phone number that was no longer working, we were kind of able to jump on it right away and get updated information by emailing them, and to kind of not lose track for them. It also kind of gave us multiple chances to get the same information. So if we sent them a survey in February about their health and they didn't respond to it, and then maybe we sent them another survey again in July about their health and they did respond, right? So we got kind of multiple chances to look at people throughout the year. For the purpose of our analysis, we're going to treat surveys completed within the same 12-month period as capturing the same information. So then in addition to these short online surveys, we also had 2 enumerated surveys that we'd used the University of Michigan Survey Research Organization to conduct. So these were like an interviewer calling people on the phone. This is the group that does, the HRS and other big surveys. So we feel like this is pretty high quality information, because if they actually were reporting this to a person rather than just taking it onto the phone. Then we also had some types of information that was kind of complicated to collect over an online survey, and we had a mobile phone app that we used to collect that, so time diaries, for example. At the very end of the intervention and in the post-intervention period, we did blood draws to get some measures of like A1C and cholesterol and some kind of underlying clinical measures of health. And then we have a couple administrative data sources. We have credit report data that I can get medical debt measures from, and then mortality, which we get from the Numinate file, which is based on the Social Security records. Yeah.
Do you collect information on drugs that they're using for the blood draws?
We did not drug test them. we thought about drug testing them, and we debated it, but we felt like it was a little bit, kind of like a violation of our understanding of each other. We told them they could use the money on anything, and now we're coming in and drug testing them. We felt it might leave a bad taste in the participants' mouth. So we decided not to do that. So we don't know, we asked them what drugs they use and they respond. And I can show you those results, but we didn't actually do like a drug test. Okay, so here are our response rates to like what I would call the simpler or the easier surveys to respond to. And so, you know, we were just super, super pleased that such a large fraction of the sample responded. You know, over, 93% did at least one Qualtrics survey in each year. And then we have similarly like really high response rates to these enumerated surveys that we have interviewers doing. Yeah.
Are the payments tied to their responding in some way? Like those are insanely high response rates.
They were not. It was important that they weren't for tax purposes. They did get additional payments for responding.
How much?
$10 per month, or $10 for each Qualtrics survey that they did. And then I think we gave $15 for the time diaries because they took longer. And then the enumerated surveys, they got $50 for, because these are like 2-hour-long surveys.
So why do you think the response rates are so good? Is it because maybe they think that their payments are contingent on their responses?
It might be that. It might be that we're paying them every month and they, even though they know they'll keep getting it, they feel a sense of obligation. We're working with the city of Chicago and Cook County right now on like these follow-up RCTs, and the control group is not getting the $50 a month, and the response rate in the control group is very low. Like, so I think the fact that the control group is still getting paid every month from us, even though they're getting paid much less, is maybe contributing to our success in getting them to respond. We also, I should say, like the OpenResearch team just did an amazing job at managing the operations of the survey. So if they didn't respond to like 2 surveys in a row, there was like a whole protocol, like, okay, we email them. Okay, if they don't respond to email them, we call them. We would send them postcards that had QR codes on them saying, we need your help to understand this program. And, we did I would say very aggressive and very costly follow-up also to get the response rates high. So.
Is part of the high response rate also that you had this strategy of, monthly, giving them monthly questionnaires? So you get basically 12 attempts with each participant for each year. And maybe that's a good lesson for future studies, that was an effective strategy.
Yeah, I think that's part of it too. And that did let us catch. So if we had just done the midline and the end line, that would be people that we hadn't interacted with for a year and a half before midline started. And we might have just lost them to they moved, they changed their name, they got incarcerated, whatever. And we just could never capture them back. So I think the monthly, just staying in touch and getting constantly updated information about them helped. At SRO, enumerated surveys are really costly, and I think we were kind of like annoyed to some extent at how costly they were, but they just did such a great job. Like they would go to the person's house, they go to the last known address, they'd call the people that were like other points of contact. They were really, really good at getting people to participate. So that helped also. Yeah.
Are these the response rates of people who initially agreed to be part of the research study, or are these the response rates of people who received the money? Like, did you have an initial, kind of?
So everyone, so everyone who received the money agreed to be contacted for research.
Wow.
So, but they didn't all agree to have their administrative data records linked. And so, and of course you can agree to be contacted for research, but not respond. So that was really good. But so this is of the full sample.
What percentage agreed to have their administrative records linked?
87%, I want to say, something like that. And it was, sorry to just give anecdotes, but it was like 95% when we were doing in-person enrollment. It was really high. And I think that's because someone showed up with a clipboard with a University of Michigan logo. It was a human being that sat down with them and did all this stuff. We had to pull everyone back from the field and switch to phone over COVID. And the response, the consent rates dropped a lot when it went over the phone. So I think that was part of that. Okay, so these are kind of our simplest surveys. We also had these like time diary apps that we did. We suspected from existing work that people might reduce their labor supply somewhat in response to the transfer and consume more leisure, right? Like that makes a lot of sense. And if they were reducing the amount of time they spent working, we wanted to know what were they doing instead? Were they enjoying leisure? Were they taking care of their kids? Were they volunteering? You know, were they doing home production, et cetera? And so we wanted to learn about their time use, but it's very hard and annoying to figure that out. And so we had this mobile app that was developed to kind of figure that out. So it looked like this. You just had like a Google interface where you could drag and drop different things. And then there were little drop-down menus where you could pick like what you were doing. So this was an example that I was doing before the study. This is sleeping. Then I wake up, I'm getting ready, like I'm getting my child ready to drop off, I'm driving to work, working. You know, I mean, so it's pretty straightforward. It doesn't take that long, but of course it's more annoying to do than just a simple survey. We also wanted to get at nutrition. That had been hypothesized as kind of one channel through which income could improve health. You can eat healthier food. That's also really difficult to measure. We used this ASA24 food diary, which was developed by the CDC. And so it wasn't developed by us, but it's been used by nutrition scientists to look at these things. So it asks for all the food you ate in the last 24 hours. So first ask for breakfast. This is me also, you know, experimenting with it. Okay, I was eating Cheerios. I searched for Cheerios. Then it says, okay, what kind of Cheerios do you want? There's a lot of types of Cheerios I didn't realize. I just was having regular Cheerios. And then, of course, portions are really hard to measure. And, you know, depending on the size of the bowl of Cheerios, it could have very different health content. So anyway, they have these visual prompts. We asked them to fill it out. You know, doing it myself, I was even wondering how accurately can I do this? So, you know, grain of salt, I suppose, but I think it was the best we could do. Yeah.
I just wanted to ask on some of the time use stuff.
Yeah.
I'm thinking about like decision sciences, literature, and whether or not you linked any sort of like decision science stuff to like leisure consumption, thinking about like present bias and some of this stuff, and whether you could use like response rates, like how often someone responds to the surveys and when, or the nutrition decision making or time use.
Yeah, well, we are interested in that. So we did ask people to do different things to elicit their like risk preferences and their like time preferences. So we had like a this was also in the app. We haven't actually cleaned this data up yet, but it was like a now or late. We called it the now or later game, and there'd be a certain amount of money you could get now, or you could get in the future with some interest rate, and we varied the interest rate. And then we said, okay, what if the early payment's 6 months in the future versus even farther or whatever? And so we can estimate some like beta, delta, you know, discounting parameters from that. And we also asked about some like what kind of lotteries would you want to play to get kind of some risk preference information out. But yeah, we haven't looked at that too much. I think when we were looking at labor supply stuff, we looked at the risk parameters. It does look like people are reporting being a little bit more risk loving if they get the transfer. Yeah. Okay, so then the last thing is we got blood draws to measure underlying measures of health. Part of what we were thinking is, oh no, what if we find in the surveys people are reporting they're so much healthier? Is this just Hawthorne effects, or is this actually like a true improvement in health? So we wanted some kind of quote unquote objective measure of health. We worked with this organization called Get Labs that would send a phlebotomist to people's homes or to another location if they were more comfortable to draw the blood. We could only include participants who were in the catchment area for this company. 57% agreed to provide the blood sample, which was much higher than I expected. But we had some problems with implementing it. Basically, we knew we were getting funding for this, but our actual notice of award was very delayed. And we didn't want to start collection until we kind of knew we had the money. So it started the very last month of treatment, and it continued in the post-treatment period, which is not ideal. But I think a lot of the things we're measuring don't move super quickly. And so I think we can still kind of capture changes that were at place during the treatment period. And also it's a good measure of, are there any persistent effects, right? Like, so if there's an improvement in health, but then it just instantly vanishes, that's maybe useful to know too. Okay, so for these more cumbersome, more costly data collection methods. We have lower response rates, as you would expect. And we also have somewhat worse differential response between treatment and control. So you can see, like the nutrition and the time diaries, and they kind of response rates kind of go down a little bit over time. And then the biomarkers, we also have kind of a bigger differential response. We have a lot of robustness checks, like Lee bounds and different robustness checks in the appendix. I can talk about later if you're interested. Yeah.
For the health measures, could you observe whether they were taking prescription drugs that you could use to help manage some of the chronic conditions?
Yeah, we didn't. So we did think about asking, tell us all the prescription drugs you're taking, or tell us all the chronic illnesses you've been diagnosed with. We didn't end up doing something like that just because our surveys were like the enumerated surveys ended up being so long that we had to cut it. So we didn't ask them. We have some hope that we can maybe link to claims data in the future. We don't see any differential enrollment in Medicaid. So if we could get like Medicaid claims data and we could actually see that, that would be really cool. We'll see. We can do it. Great. Okay. So, estimation is really straightforward. We just have a treatment indicator. We include some baseline covariates just to improve precision. We have a large number of covariates we could include, so we just select the most relevant ones using the lasso. And then, as I mentioned, you can see each time period estimated separately in the paper, but so I can just give you a single number. We pre-specified that we were going to weight the times together and put more weight on the observations at the end of the study. I'll show you the regular unadjusted per comparison p-values as well as the ones that are adjusted to control the false discovery rate. Okay. So at the top, so here's our first set of results. At the top of the panel in bold, I have something called the self-reported physical health index. So everything in this table is something about their health that they reported in a survey. At the top, we've aggregated all of these kind of underlying components to a single measure. So if you're interested in, and it's measured in standard deviation. So if you're interested in overall, did physical health change? If I looked at all these measures together, you would want to look at this bold number at the top. And what you can see, this is the treatment effect. It's in standard deviations. If anything, physical health was a little bit worse, but by a very trivially small amount, 0.017 standard deviations, right? And not statistically significant. Then we can look at each kind of component that goes into the index. Some of the components are only involve one question. So this first one is, how many days of the last 30 days were you in good physical health? On average, the control group says 26 days. And then if anything, the treatment group is saying very small effect, but saying actually slightly fewer days. It has 2 stars because it's significant with, quote unquote, traditional inference, but if it was also significant after adjusting for multiple comparisons, it would have some dagger symbols here. So it's not statistically significant. We also ask, rate your health from poor to excellent. And then we have a series of questions from what's called the SF12, which is a validated survey of health. It's in the HRS, for example, about health limitations. Does health limit moderate activity? It goes from 1 to 3, 3 being yes, very much, and 1 being no, not at all. Is health limiting your ability to climb stairs? Are you accomplishing less because of physical health? And what we see is, no statistically significant difference for any of these effects. Of course, if you get no effects, you're always kind of wondering, is this 0 or is this just kind of mush, right? Like, is this just some sort of non-precise effect? So in this column, I'm going to show you the size of an effect that our 95% confidence interval can rule out. And you can see we can actually rule out very small effects. So the top, since it's measured in standard deviations, I'm reporting it in standard deviations, we can rule out, an 0.02 improvement in the overall index of physical health. And then these are reported as like a % of the control group mean, and we can rule out, very small improvements in these measures. Yeah.
Are we using the multiple hypothesis testing, I guess, statistic for the thing on the right, or is those?
No, so this is just based on the normal confidence interval that you would get. I think it's kind of like an interesting conceptual question. Should we think that we have more uncertainty about? And so the thing that's a little tricky with the adjustment for hypothesis testing, it's really about testing, like yes or no, and not really a measure of uncertainty. Now, I think personally, if I looked at a bunch of measures and I found null effects for all of them, it would make me feel like more confident that there was a null effect to some extent. I think, you know, if you took a purely frequentist perspective, you might want to make the confidence intervals bigger.
Yeah.
But that's not
I
totally
shouldn't
obvious.
think about this as being, if I really believe that we should be adjusting for multiple hypothesis testing, I should just kind of ignore everything except for the daggers then. You're not gonna give me anything else to.
Yeah, so this is all null, and then there's a question of like, should you think the effect possibly could be bigger because I'm showing you a lot of nulls, or
Presumably there's some multiple hypothesis testing adjusted confidence interval, and I guess it sounds like you're
Yeah.
giving us the bound on the right bound on the, or the left bound.
Yeah,
whatever
yeah.
is the appropriate side on the non-adjusted confidence interval.
Yeah.
And I guess if I wanted to try and do this in my head, what's the analog to like 1.96 that I should be using for the multiple hypothesis testing?
It depends. So the way that we're doing it depends on the rank of the p-value. So like you could, so the way the false discovery adjustment works is basically you, well, okay, so I don't have a lot of time just to say it would be like, there's not one single number, 1.96. It would be different for different outcomes. But you can imagine I could give you the set of all null hypotheses that can be rejected after adjusting for, like you can make a confidence interval.
It's just not gonna be as trivial for me to do in my head.
I don't think you can do it in your head unless you're, it's not complicated, but you'd have to be like really good at mental math. I think it's, so I have another paper that has a bunch of null results, and I think it's not obvious to me that when you have a significant result and you're saying, is this really significant? That seems different to me than like you have a null result and you want to say something about uncertainty, but
I just want the confidence.
Yeah.
I want to know whether it's significant or not.
you might be able to figure that out. You can figure that out with the information in the table. I will say that. You just need all the p-values and you need to rank them. Okay. So next, the grade, so, you know, this is a relatively young sample. You might think it's a relatively healthy sample. Would we actually expect to find an effect based on the kind of variation in income we see in the control group and the outcomes we see in the control group? That's kind of what this column's trying to get at to some extent. So if we took the correlation between income and the outcome in the control group as fully causal, how much of an effect do we think this $12,000 per year transfer would have? That's what this gradient is. Right? And these double daggers just say that this gradient lies outside of our 90th, 95th, or 95%, or 99% confidence interval based on the per comparison for yourself to that. Yes.
So just to make sure I understand. So the gradient's based on like actual like, labor income. So that's like a permanent income. So the gradient here is like a permanent income change of $1,000 to do something, not the net present value of a 3-year payment.
So this basically is saying, what was the control group's income at baseline, and what was, or at, actually it's weighted over the 3-year period. So anyway, what was the control group's income, and includes permanent and transitory income, their total income, and then what was the predicted difference in their outcomes based on that income, right? And so it's just trying to say, you know, I talked a lot about income gradients, but like you might be worried because it's a young sample, actually, maybe there's not that much variation over income, right? Like, and so it's saying, no, actually, you know, these do look better in the control group for people that have higher income. And we might have guessed, if we were very, very naive, we might have guessed that these were like the causal effects. Okay, so this is basically continuing that table. So I couldn't fit all of the outcomes in that table and have it still be legible, but basically there's additional SF12 questions about limitations, and then a question also from the SF12 about whether pain interferes with normal work. But it's kind of the same story in the sense that we can rule out like pretty small effects of less than 5% of the control group mean. Okay, so physical health isn't changing, but I think you might think, well, maybe it takes a long time to change physical health. Maybe it takes years and years and years to change behavior. But maybe mental health would change quickly if people are less stressed out. So we next look at mental health, and the table is set up the same way. So overall, you can see, again, very small, not statistically significant effect on mental health outcomes overall, and we can reject kind of a very relatively small improvement of about 0.03 standard deviations. Then we have a series of kind of components of this index. So first, this is also from that SF12 questionnaire about whether emotional problems are interfering with daily life. or higher responses indicate more interference. And we don't find any improvement on these, and we can reject really small effects. The Kessler 6 is about kind of generalized mental distress. So it's 6 questions that are like, how often did you feel nervous? How often did you feel worthless? How often did you feel that everything was an effort? We don't find an effect here. The perceived stress scale is kind of a 10-question validated measure of your subjective experiences of stress. We don't find changes there. We look at anxiety, questions related to anxiety, depression, and day's mental health was good out of the last 30. But yeah, it's a little repetitive, I guess.
Show us that this 2023, there's this zero, no effects.
Even in 2023?
Yeah. Oh, okay.
So something like this, I think, is what you're looking for. So here's the stress score. I've standardized it to be in standard deviations. And this is the pattern. And we see this for the K6 too. And then there's some other measures that are like affect balance that aren't in this paper, where we see a similar pattern. But year 1, we see a statistically significant effect. Year 2, it's like right on 0, right? So like this is kind of an interesting pattern that they're having less stress in year 1, year 2 it's 0, and then year 3 it's not significant, but perhaps in anticipation of the end of the transfers, it's even a little bit higher in the treatment group.
Can I ask you, so the 2 papers that come to mind are like the Cicerini and co-authors paper of lotteries that also seem to find some effects on mental health and no effects on admin, like healthcare utilization.
Yeah.
And then the UCTs in Kenya that also find reductions in stress, like cortisol, and then I think no effects on self-reported health.
Yeah.
How different are the magnitudes that you find relative to those 2 papers that are coming to mind that find similar results?
Yeah, well, I remember the Cicerini et al. Results being relatively small, and they're measuring, having prescription drug use for that.
That's all admin data.
That's all based on admin data. I don't remember off the top of the magnitude of the Kenya RCTs, but I know there have actually been a few unconditional cash transfers in a variety of developing countries and have tended to find improvements in mental health, but I don't think it's like kind of across the board. But yeah, I should have the magnitude handy, but I do remember the Cicerini et al. Paper, it being pretty small. Yeah. Okay, so this is our measures that we have derived from blood draws. And again, you can see no statistically significant effect, relatively, small upper bounds for a 95% confidence interval. When we look overall, of course, when we look at any given measure, and this is a smaller sample as well, we can have a lot more uncertainty, right? So overall A1C, the average isn't changing, but the probability of being in the diabetic range, right? A1C is like a measure of blood sugar. We have a good amount of uncertainty about that. So I know I'm kind of getting towards the end of my time, so I'm going to kind of, I think, move along. So we don't find clinical measures of health. We don't find an effect on mortality, but we have very low mortality rates in the sample. We have a very high upper bound of the confidence interval, so hard to say. This was very surprising to me to look at just measures of their perceived access to medical care. So we look at, like, do they have health insurance? Are they worried about paying medical bills? Are they skipping other bills to pay for healthcare? In general, these are going kind of in the quote unquote right direction, but they're just not statistically significant. And they're reasonably small. Was there medical care that you needed but didn't get? Here, we don't find effects. Maybe if anything, it gets a little worse for dental care. As I'll show you, they're getting more dental care. So that it might be that they go to the dentist and the dentist says, oh, you need $30,000 of dental work. And they're like, oh, I'm not going to get that. So that could be perhaps due to this perception. And then when we look, I know insurance came up, but how much are you spending on insurance premiums? About $13 more. That's not significant. Oh, shoot. I just pressed. Okay, I went to the end of my study. Okay.
You said that the other admin data was credit report data, but that's not going to be part of this.
Sorry, this is the credit. This is from the credit report. So this is medical bills sent to third-party collectors. Now I'm just going quickly, but and you can see, yeah, went down maybe, but it's not statistically significant. And we have another paper that has like all of the credit report outcomes. So office-based care, I was asked about this and I said, well, if you take a step back and you kind of squint, maybe there's somewhat of an increase. So you can see that there's increase in the overall index of office-based care, but not if you adjust for multiple comparisons. Maybe slight increase in the number of doctors' office visits. Maybe a little bit slight increase in specialty visits, but again, not super precise. We do see something going on with dental care that's significant at the 10% level after adjusting for multiple hypothesis, the fact that we're doing multiple hypothesis testing. And we do see another significant effect, which is just the amount they're paying out of pocket for medical care. Like your copays and your coinsurance goes up by about $20 in the treatment group. All right, so you can use that to calculate like a marginal propensity to consume medical care, and you'll find it's actually pretty small. Hospital and emergency department care, here we do see some effects that seem to survive our adjustment. So we can see kind of emergency department care is going up by about 0.08 standard deviations. It's significant at the 5% level when we apply the adjustment. Looks like it's coming from both the number and both the intensive and extensive margin. Also, it looks like maybe some evidence that hospital visits are going up by about 0.065 standard deviations. And it's about, the number is going up by about 0.06 hospitalizations on a base of 0.23, so it's pretty large. So it does seem like some types of care that people are using is going up. We don't find much when it comes to health behaviors like exercise, sleep. We don't find any significant effects. If anything, it's kind of going somewhat in the wrong direction for exercise. So it doesn't seem like it improved health behaviors. We look at nutrition and food security. Again, not significant after adjustment, but maybe a little bit of improvement in nutrition, and depending on how seriously you want to take the unadjusted p-values. Food security or food insecurity is interesting. It has interesting time patterns because it looks similar to the mental health piece. Really big effects in the first year. Reductions in food insecurity. By year 2, they're smaller. At the midline enumerated survey, there's 0. Year 3, there's 0, and then there's 0. Yeah.
Can I ask you how this particular graph compared to the other results that you have in terms of labor supply and consumption of other goods? Like, do you see also like immediate effects that are just temporary, short term, and then is it that consumption is changing over time? Is that they immediately like kind of resolve their immediate like health needs or whatever, and then eventually they start changing their use of the money?
So just overall consumption goes up and stays up, right?
I see.
Labor supply goes down and stays down. What does potentially change is, or one thing that we're kind of thinking this might reflect is that their liquidity might not stay high, in the sense that, you move to a new apartment, now you have higher rent. You get a new car, now you have a car payment. And at the end of the month, you might still feel illiquid, right? Like you don't have cash in your pocket. And we think this is maybe capturing the fact that a lot of the consumption went into things that have these like longer term contracts associated with them. Okay, so I know that I'm out of time, so I'm just gonna kind of skip to the end. We don't really find much here. I can talk more about heterogeneity. I think I'll just end with this, which is that, there's been a lot of enthusiasm for this idea that to address health disparities, we should be targeting like this material dimension. And I think on one, it sounds really good, but I think the flip side of that is it can be quite pessimistic. Like, I was on a panel last year where someone said, we can't improve health outcomes until we first solve poverty, which to me seems like a very kind of negative lens to see this. And I look at this kind of constellation of results, and to me what it says is that it's unlikely that, at least over this period that we're studying, that cash is going to improve all these health outcomes. Why is that? Well, why do economists like cash? We like it because everyone can spend it on something different, right? I might spend it on health. You might spend it on your car. You might get spend it on your kids or whatever. Everyone's spending it on something a little bit different. And that makes it kind of a blunt instrument for any sort of really specific thing that you might want to move as a policymaker. So I'd say one thing that I feel like I take away from these results is that if what you really, really care about is health, an intervention that's directly targeted to health like health insurance, like making prescription drugs cheaper, like many other very health specific things that have been validated with RCTs to improve a lot of these outcomes, that's probably what you want. If what you care about is just letting people consume what they want, reducing inequality in consumption, making people better off, nothing in this talk says that cash doesn't work for those things. It's just kind of a blunt instrument for health specifically. Okay, so sorry to keep you late, but thanks so much for all the great comments.